All right, thank you, everyone. I know more people are probably going to be joining us shortly, but in the interest of time and our guest speakers, I want to make sure they've got ample time to cover their content. I am Gary Beck-Dallahan. I'm the director for the Alliance for Clinical Education. And this is part of our clinical faculty development series. I'd forgotten to change the slide to be 201 because we're in the second year of it. But this one's on health system science, and we're ecstatic that we have Luan, Lawson, and Gonzalo as our presenters today. Luan, can you click the next slide? So we did apply and get CME credit for these sessions through the University of North Carolina. And so I take attendance at this, so that way I can submit the information to them and they'll reach out to you after a period of time to notify you about how to obtain the CME credit if you're so wishing to get that. Next slide. So we've created this series just briefly because we wanted to do a little bit more in-depth follow-up of what we've published in the guidebook for clerkship directors. And so this is just a way for us to provide some faculty development on some of those key content areas that are in the guidebook. And it's a 3-year series. The first year was done last year, and all of those recordings from those sessions are on our website, the allianceforclinical.education.org. And we're working through, this is our second year right now. So we'll be continuing to do these things through May on a monthly basis. So next slide. So this is just a real quick recap of what we covered last year. And like I said, if you go to the website, you'll see these, but you'll also see a link to the YouTube channel that we have with the recordings of all of these on it. Next slide. So last month we did our interprofessional education one. This month we have health system science. We are going to have to delay the integrating basic sciences one because the speaker that we've been trying to secure has not gotten back to us. So we'll be moving that to a later date or probably next year. But the plan is for the rest of the year to cover these, or 2023. Next. And this will be our third year. And we'll be working on getting those dates secured over the next few months and stuff like that with the speakers and be able to present those to everybody. Next slide. And this is basically a cover shot of the guidebook for clerkship directors, 5th edition. We're actually in the process of talking about starting to work on the 6th edition. So that will be coming in the next couple of years. But this is one of the chapters that's in the book. And like I said, we're happy that Luan and Jed are here to do the conversation. Next, hopefully this is you guys getting started. There we go.
All right. Thank you all so much for the opportunity to be here and to have an opportunity to share some of our experiences with you and hopefully answer some questions. I will say that it is remarkable having looked at the last guidebook and a lot of the work that has gone on in health system science and really sort of reflecting on how much I think this as a content area is changing and has changed in just a very short amount of time. So hopefully we'll continue to have that forward driving force of innovation. And so what we're really going to talk to you today about is describing what exactly is health system science, hopefully convincing many of you that you have this skill set, while some of the verbiage and terminology may be a little different, this is stuff that is actually well incorporated into much of what you know, although there are definitely pockets for being able to expand our teachers related to that. This is really essentially, it is the third pillar of medical education. We're going to talk about how to integrate this into the clerkships as well as other curricular opportunities, describe some of the opportunities and challenges, and really identify sort of where we need to go, particularly in terms of assessment. And we're going to structure that around these 4 concepts as we move through the slide. So initially, we're going to start with this idea of about systems-based practice and how that really has driven forward the field of health system science. And these are all things that you know. Really started if we look at the ACGME core competencies. A lot of this content has historically been embedded in systems-based practice, but has really had an and covers multiple other areas as well in terms of the interprofessionalism, some of the aspects of PBLI, but it's really firmly grounded in systems-based practice. And that's initially where a lot of this history began. And if we look at the original definitions of systems-based practice, it really talked about the responsiveness to the larger content and the system of healthcare and how to effectively manage the other resources within the system to provide optimal care. And when you look specifically at that, they had the expectations about working in various healthcare delivery systems, really to deliver coordinated care to our patients, regardless of what specialty that they were participating in. Thinking about high value care, what we really more commonly talk about now, but thinking about cost awareness and that risk benefit evaluation, interprofessional teams, systems errors. And this really formed the basis of health system science. Jed is going to talk about a lot more on how health system science has grown to be more inclusive of some other essential topics that were initially left off of this.
Yep. Thank you, Luan. Thanks to Gary and the team for inviting us. So it's a great segue into this articulation of the conceptual model of the three pillars of U.S. medical education. We know that we have worked in a dyadic two-pillar model well over a century ago until today. But health system science, the last 7, 8, 10 years really has coalesced a number of competency areas into one unifying framework that ideally would work synergistically and be integrated with basic and clinical sciences. And this is the definition that we put forward for health system science in our textbooks: the principles, methods, and practice of improving quality, outcomes, and cost of care delivery for patients of populations within systems of care. So if you can advance to the next slide. So I in years past, I never did this slide, but I found the need to be doing this because a lot of folks would say, oh, this is the next new thing. This is something that just came up in recent years. And for us who were in the field or the discipline, we didn't believe that. It was actually in the genesis for well over a century. So this is just a very brief historical walk through some of the key milestones for the evolution in the HSS. And it starts all the way back at the Flexner Report, which established the basic and clinical sciences as a two-pillar model, which then led to the next milestone of Ernest Emery Codman, an anesthesiologist at Harvard, who began to look at the end results card system, where they would record how patients were doing, not at the end of a surgical visit, but after 30 days, after 60 days, which really allowed us to look at structures driving outcomes. Interprofessional education started in Europe in the literature and made its way into the US in the 90s and 2000s, but really opened up space for interprofessionalism. Engel's biopsychosocial model, in addition to numerous other frameworks, shined light upon the idea that it's more than the biomedical diagnosis, it's the social determinants of health, it's the systemic factors, and this patient-centered framing for patient care. The Libby Zion case, 18-year-old woman admitted to a New York City hospital, dies within 12 hours, presumably from a drug-to-drug interaction. Several years of litigation, but also a reflective practice on medical education, looking at patient safety and the education competencies for our trainees. The Harvard Medical Practice Study was one of the pivotal sets of studies looking at hospitalizations and identifying that 4% of our outcomes, or 4% of hospitalizations, have poor outcomes and adverse events. And this context drove the systems-based practice competency to be created that Luan already identified. And it also happened in the context of the IOM reports here in 2001 that really shine light on patient safety, quality, the structures. The first foray in the post-SBP competency was really in quality improvement. One of the first QI rotations, when you look in the literature in the GME space, shine light on QI and patient safety. The AAMC recommendations for social determinants of health around 2007. I mean, all of our medical schools have social determinants of health as a key part of our curriculum. The first College of Population Health at Jefferson gave a name to population health and medical education. Data on waste and value from Berwick et al. Allowed us to open up another subset around high value care and cost consciousness. And then the clinical learning environment review from the ACGME really prompted us to look at the environments. Are our environments conducive to the practice, learning, and teaching of systems-based practice and health system science? HSS was coined in 2015, which kind of established it, or at least as a draft, as the third pillar of medical education. We do know that it's over 110, 120 medical schools based upon our data, which is a significant proportion. And then the last few milestones 2.0 further is pushing SBP and HSS. And then you can circle it out, Luan, on these last set of milestones. HSS and SBP being further integrated. And my last click here, this is what I hope you take away from this very brief historical journey, is that HSS is built on evidence. It's been evidence that has been growing for the past over a century, and its primary focus is on patients. And I think this is one of the potential misunderstandings that Luan and I hear, is that it's out there, it's the system, it's policy, it's Capitol Hill. It's actually grounded very much in improving patient health outcomes within the healthcare delivery system through the competencies of physicians in this context. And this is the model that we created around health system science. I think, Luan, this is 2016. This is 6 years old now, 7 years old. And there's 12 distinct competency areas. Many of them that you can see came from the field from over 100 years of work. But our core domains are in the center: the structure and process of care delivery, improvement, value, all the social determinants of health, informatics. We've got a number of cross-linking domains of teaming and change management advocacy. And systems thinking is the one that encompasses all of these. This framework is built from several research studies, actually, that looked at some of the perspectives on what health systems leaders believe that physicians need for skills. And systems thinking was one of the most unique competencies that emerged from that data. And it was also a key part of the founding of systems-based practice in the 1990s. So what I hope you see from this slide is a comprehensive framework for the systems-based competencies. It's not one or two, it's comprehensive, it's synergistic, and there's 12 plus that have many sub-theme areas, but 12 key competency areas.
And Jed, I wonder if you'll just comment on a little bit of what is systems thinking versus thinking about systems, which I think is a confounding issue for a lot of folks.
Thank you, Luan. So Luan and I are laughing because we've asked medical schools, hey, yeah, we do a lot of systems thinking, and you do a deep dive, and they'll tell you, well, what we're doing is we're teaching about the healthcare delivery system. Systems thinking, as it informed the systems-based practice competency, was a philosophy, a mindset, a specific set of tools and skills for physicians that is very systematic. I mean, for example, we have a whole systems thinking curriculum in my prior medical school where you're marching through these competencies. So it's more than just thinking about systems. It's a set of tools, and it's a mindset for a physician in this context that integrates all of these competency areas together.
And so the question really becomes, why is this important to bring and coalesce all of this existing framework together? And one of our challenges, especially in the very beginning of this, when we spoke about health system science, it was really people were equating this specifically to patient safety and quality improvement. But without having a singular comprehensive framework, and without understanding what those competencies are, we're really unable to hand the baton from UME to GME to the workforce. And then additionally, it makes it even more difficult if we don't know what the expectations are for our learners at each space. How do we actually begin the curriculum? How do we make sure that we hand off to one another? And what are the realistic expectations around assessment towards them? And especially as you're thinking about this in terms of match or in the workforce, what really happens then is that they're shifting expectations. Our students may be experts at one medical school and then go to a different institution where they are really the leaders, but maybe not not have faculty share with their expectations or enthusiasm for that, which creates a disconnect. And alternatively, it sets some learners up to be potentially behind other learners. And then I'll let Jed talk a little bit about some additional challenge with that and how to catalyze this in the system citizens.
Thanks, Lynn. The mantra, I think, from this slide is the yes and idea. that what we were experiencing early on is that, oh, we have a health system science curriculum. We do quality improvement for 6 blocks or 6 sessions, or we do high value care. We saw a whole bunch of popcorn that was happening, and any one of those domain areas is absolutely critical. It's a yes, like that is so good. And what we were seeking was this more synthetic, comprehensive approach to really thinking about the comprehensive set of competencies that included high value care or quality improvement or interprofessional collaboration or the social determinants of health in this very synergistic manner. So that's one of the reasons why HSS it extended decades of work. None of it was novel. The synthetic framework, I think, was the novel piece. But really, not the money is in, for me and Luan, is really in number 6. It's this shift towards this evolving professional identity of healthcare physicians and clinicians as system citizens, that it's not aspirational to be learning these health system science competencies in a comprehensive way, but it's part of our identity and part of our role as a healthcare professional, which gets us into this system citizen idea, which is all about professional identity. We gave a tentative definition of a professional who uses systems thinking and the mindset in their role to develop and use the knowledge and skills necessary to contribute to the holistic needs of individual patients and populations, but also the health system. That yes, it's about the patient in front of you, and it's also about this community of practice that's occurring in that microsystem, in the unit, the operating room, or the hospital ward. So a lot of our research has been around the system citizen concept, and this table is just showing some representative ideas of the characteristics, the attitudes, the skills, the habits of what a system citizen would do, what they know, what their attitudes are. So I think that the take-home point on the last 2 slides, I hope, is that it's health system science and systems-based practice are certainly behaviors and skills, and it's also growing into this evolving identity of the healthcare professional to really meet the outcomes of patients.
And I think even as I think about these things, I think about my own personal training and what limited training that I had related to any of these concepts. And there was so much focus on the myriad of other aspects that are important to being a physician, but where we spend so much of our day is living in this land, and especially as our healthcare system continues to rapidly evolve. And so really the question for you all is, how do we actually begin to prepare our students so that they have the skills that they need to continue to help driving those changes forward, and really allow us to develop a system where the patient is at the center and we're achieving the types of healthcare outcomes that we wish to achieve. And so I'm going to take you through some examples about how medical schools are incorporating HSS into the core curriculum. One of the things, and these are highlights from several exemplar schools. And so the high level here is there is a vast variety in what medical schools are doing, how they're presenting the information. I think Jed and I would certainly agree, and we hope to convince you of this as well. I think the real place we can make a difference is at the bedside. And so how do we actually use this to transform clinical care? But if you look at this, you'll see a lot of the challenges are that a lot of this content is actually embedded in the preclinical curriculum. There's places that have incorporated into the clerkship, and I'm going to share my example next, but I would say it is really difficult to move this from these exercise-oriented types of foundational information to how can we ensure that this is enacted at the bedside on a daily basis. But really throughout this, you can see, I mean, compared to a decade ago, there was very little of this content at all. There's been a significant uptake in how we have incorporated these things within the UME curriculum, and that for many places is actually incorporated throughout that continuum of UME, from the pre-clerkship phase to the post-clerkship phase. But we still have a lot of work to do as to determine how to make this more meaningful. I'm going to share with you. So I was previously at Brody School of Medicine at East Carolina University. as we began to really take this on in that sort of 2013, 2014, 2015 era, we were challenged with how do we actually incorporate this? We already had an overburdened curriculum. We're talking on one hand about how to cut out non-essential topics, and then at the same time, how to incorporate these topics. And so we took an approach to this of actually mapping out the entire curriculum and seeing where there were opportunities, where were we already actually doing this? Because a large part of the journey here was actually convincing people that they knew some of this, that they were already teaching this. And then we actually worked with our clerkship directors in order to think about what are the core concepts that are essential that you think as they move on to residency that they are going to need to know, and how do we incorporate this in a meaningful way into the clerkships? This doesn't actually begin to address the patient care at the bedside piece that I would like. So simultaneously, we actually ran a pretty significant faculty development program where we were training our faculty up so that they felt like they had the skills and could help lead that clinical transformation piece. But there are really some unique opportunities here that don't take away significant time, and things that we need to be more explicit in how we share this with our learners. So for example, in the OR, checklists are not new. They have been used for a while. We're not always explicit to our learners about how they came about, why they came about, and what they are designed to do. And so some of this is actually being able to articulate to our learners why things are happening in the environment, as opposed to it being more of a hidden curriculum. And we really just didn't think to tell our learners that. Also, there's some unique opportunities here in which we struggled with our faculty initially saying, I don't have the expertise. There's no way our learners could have the expertise. And this is a problem that can wait to residency. And our OB clerkship director really thought about this in a different way and wanted to teach students how to use fishbones, how to use this to drive solutions to clinical problems. And when we started this, throughput in the OR wasn't even nearly as big as a challenge as it is for many of us today in our sort of post-COVID era. But that is a challenge for many institutions. And so she actually had the medical students work together in teams to come up with a fishbone analysis of why there were challenges with throughput in the OR, and really found that the students, because they are a little bit further removed from the system and maybe not so entrenched in the historical aspects or the urban legends that we live on in our clinical departments, were actually able to come up with tremendous, phenomenal ideas that really led to some change within those situations that they were able to implement and to put into place. Additionally, we had a patient navigation experience, which is unlike JEDS that was much deeper, but it was a one-time issue where they navigated the healthcare system with the patients and really looked at the systems issues. And we identified incredibly simplistic solutions that were tremendous impediments to patient care. So what we found is that in one of our outpatient clinics, that the signage was so poor that people couldn't actually get from the physician's area to get to the lab, and were getting lost in the process. And so we were able to have the students actually present these to the healthcare system president, and were able to put solutions in place that hopefully actually translated into improved patient care.
Luan, could you go back? I just want to comment on, because I know Luan's work over the years, and there's two things I just want to highlight here for some tangible takeaways, I think, for everybody. The first is the idea of intentional design. This is not ad hoc. This is intentionally designed to be synthetic for the learner across the continuum. And the second piece is the concept of integration, both vertical and horizontal. So what's evidently clear on here is the vertical integration that occurs through the year M1, M2, M3, M4 year, and is very intentional. And the horizontal integration doesn't get captured here too. And I think it's much harder to be integrating with some of the key other core competency areas. I have found that to be the bigger challenge. I know Luan has as well. So in some ways, vertical integration might be easier, but they're the two things I don't want to get lost on what you just presented, Luan.
No, thank you. And I will say the other challenge with this approach is that it is so embedded within the core content and the clinical specialties of what they're learning that many times our students did not recognize that this was health system science. And we really had to actually do a lot of work around signposting the content so that they understood that while it is deeply embedded and immersed in what we do, there is actually a science behind this that drives this forward, and being able to call that out in a meaningful way is very important. Otherwise, you potentially, what happened to us, we would get to the end of the year and we were really proud of some of the innovations that we had made, and the students are like, we just learned patient care stuff. This wasn't really health system science. And so you have to be intentional about the delivery of that. But it also allowed us to integrate in such a way that it did not take up significant clinical or other curricular space that was such a commodity.
So we're going to show you two more examples, predominantly in the clerkship, and I'll be brief on these. This is one coming from Virginia Tech Curriculum, where I am now, and I want to credit Drs. Natalie Karp, Sarah Parker, Sherry Wicker, who, and in addition to their teams who have done this work. But this is specifically in the clerkships. And the concept here is that the medical school identified and hired faculty physicians, one from each of our 9 core clerkships, and each received 0.1 FTE of dedicated funding to be the health system science and interprofessionalism champion. So it's essentially building another cadre of faculty who are there to champion and shepherd in a lot of the health system science core learning areas within the clerkships. As they come into the group, they have a year-long faculty development course in health system science that our teaching academy leads. They learn the core skills in that early year, and then they develop and lead HSS curricular areas for each of the clerkships. And what's mapped on the right is the health system science framework aligned with which clerkship is doing what. So family medicine doing some experiences and curriculum in high-value cost-conscious care, psychiatry, clinical informatics, OB-GYN taking an equity lens. So you can see that any one clerkship doesn't need to do all these different areas, but when you look across the full clerkships, there's a comprehensive degree, if you will, of health system science learning in this phase of our curriculum. They also facilitate some in the small groups early in the year, and they really take on this idea of department championing around health system science, which gets at some of the cultural stuff that Luan was talking about, the change management piece around health system science in the vernacular medical education, just as SBP or systems-based practice had a challenge. They're also being the champions of the language and the narrative. So one example right there at Virginia Tech, which we'll give you another one here of Kaiser Permanente on the next slide, Luan, School of Medicine. And I want to credit Dr. Tony Burgos, the PEDS Clerkship Director and a member of the HSS faculty, and Dr. Lindsay Mazzotti. So again, this is in their phase 2, which is their clerkship phase. I'm giving you the salient points. They have a very robust program. They have a robust curriculum in HSS, which is so significant. It's one of the exemplars, even though they haven't fully graduated their first group of students. It's an exemplar for HSS education in a medical school. They have this dyadic model here of, they call it Quest, the team-based projects. They're year-long projects. The students lead these projects. They're coached by quality leads within the health system. And they identify system needs that are occurring within the microsystem or that health system. So for example, in 21-22, they chose colorectal cancer screening. Current year is hypertension. They design and implement the improvement intervention. They have a bunch of assessments where they need to report out oral presentations, and it's directly aligned with what this health system needs are in those projects. On the right side is the curriculum itself. There's a number of assignments, experiences, learning pieces that are occurring across all the clerkship. And the clerkships don't do every piece of the HSS wheel. They do one component of HSS. But again, the learner's experience over the course of their clerkships, they're learning the comprehensiveness of HSS, and there's the focus areas. So just another example on how clerkships are doing it. I think some of the unique features for Kaiser is the idea of their LICs, which I think is at least unique for the majority of medical schools that don't have the LIC.
So this really brings us to our next discussion. I'm just going to ask you to toss in here, and then hopefully we'll be able to come back to some of these things as we are moving forward. But how are you integrating HSS content in your clerkships? We would love to hear a little bit about that, and then we'll bring that back in our question and answer time as well. Next, we're going to move on to talk about some of the challenges with systems-based practice and health system science. And so another question for you to be thinking about are, what are some of your biggest challenges, especially as we leave time at the end for discussion, and how can we continue to learn from one another in solving these challenges? And one of the first challenges that we are going to sort of discuss, and this is some work that Jed has done, is really looking at he looked at what did medical students actually feel like their priorities should be. And medical students, when you inherently ask them, felt like their job was really to focus on understanding all of these concepts that would lead them to be the best doctor possible as they moved into their GME phase. But it is at odds with the system in which we currently have, where it is about doing well in things that are more what they perceive to be more highly valued, which are our basic and clinical sciences, which translate more regularly into their grades, their board exams, and then it is about being the most competitive in terms of getting into their best residency possible. And so we really have a challenge with our current structure and function, like we have in so many relative to so many different topics, but that does make this, it makes it a challenge for us to think about how to design a curriculum that the students value and really allows them to develop the skills in which they need.
We have a couple slides here on some of the challenges and barriers, but when I spent 9 years of my career doing health system science curriculum across every year of the medical school. And I remember in the early years, we would get, when you would look at students' perceptions of health system science in any one of the phases, clerkships included, the scores are remarkably low. And inevitably, they end up in a scoring grid that compares it to the musculoskeletal course or the internal medicine clerkship. And it's tough to see some of those scores. And I was calling around and I would call people who were doing it longer than I had been, and they would say, congratulations, we have never had student perception scores that high. And then that's what got me into understanding the change management piece of the curricular pieces of the new and innovative parts of the curriculum. So this is work that comes from higher education around when you implement a new program, either in curriculum or clerkships or graduate programs. It's the idea of the implementation dip. You introduce a change and you think this performance, whatever your goal is, you have this myth on how high it's going to go. Oh, we're at current state, we implement this, it's going to be 20 times better than what it is. But in reality, what happens is that there's a significant dip in those first, second, or third years of your implementation. And then that actual performance line takes a while to get up above where you were at baseline. And then you are in a better state, but it takes 3, 4, 5 cycles of iterative improvements to get there. And that's the slope of the line depends on a number of factors. But what we were seeing in HSS, if you click, Luan, to the next one, is that this bar of the assessments from the students never actually reached the baseline bar. It always felt like it was below this gap. So we termed it the HSS performance gap. And I used to think it was me in the first couple of years, but when you start to talk to everybody about these parts of the curriculum, you realize, for me, it's 100%. 100% of the people I would talk to, and you would have coffee discussions with them, that this never reaches the bar of other types of content, if you will, or more traditional competencies. So it's one of the things that we struggle with HSS and SVP, both in UME and GME, also interprofessional, by the way.
And just to sort of add on to that, what we noticed, and of course, the GQ questions change over time, but after we implemented our HSS curriculum, we actually had lower scores around understanding some of these concepts. And I think a lot of this was around the realization of what the students didn't know, whereas before they'd never actually really firmly had an understanding. We also had some challenges with, well, if the system is broken and needs to be changed, why haven't those of you who have come before us actually changed some of this so that we didn't have to deal with this? So it creates some interesting, some challenges that were, at least for me, unanticipated moving forward.
Thanks, Luan. You can click through these. So these come from several research studies, all qualitative, around systems-based practice, which again, systems-based practice and health system science, I would look at them as intertwined. But we did this in the GME space. What are the key challenges or barriers to systems-based practice? And these were the 4 most salient findings, is that systems-based practice, again, or HSS, is a black box. It's a nebulous idea or concept for many of our faculty, for example, on the front lines. And even our participants would say it's a black, I don't really know what it is. But to get to number 2 is that when you have the discussions about what the workflow is, what's the process of what you're doing in the operating room or as an internist on wards or outpatient preceptor, the work is demonstrating a lot of the HSS or systems-based practice principles. It just doesn't get named or identified as such. This is a great example from a nurse here about durable medical equipment, coordinating with other providers, making sure medications are set. And then he or she says, well, wait, I guess, is that SVP? Oh, yeah, we're using SVP, I guess. So you back your way into maybe that's what SVP and HSS is. And I think that's one of the challenges that we have when we're trying to connect with our faculty, or really the engine of our education mission. Number 3 was HSS and SVP need to be intentionally integrated into learning environments. Luan already said it several slides ago, but what we're finding is that, as I think is intuitive, it doesn't happen by osmosis. There needs to be this intentional design of SVP. And number 4 is it requires multidisciplinary settings and work processes, finding the positive deviance, if you will, of the pockets of really good is areas to capitalize upon where some of this learning can happen, at least for in certain clerkships, there might be a unit or a team, which is good exposure for our learners to be practicing and actually practicing or doing some of the skills. The mental model one here is really the different mental models that exist for SVP or HSS. So at the core, you probably picked up on this already, but the core to us is this comprehensive frame of systems-based practice in HSS. But when we do the research studies, the mental models on what people think SVP or HSS is tend to live either in the central camp or in these satellites around. Oh, that's quality improvement and patient safety. Oh, that's interprofessional collaborative practice, social reform, high value conscious care. And I think this is some of the language differences that we're living through. And I think we're making progress on it, to be honest. And I close on this last slide, which is some additional research that we did on students' perceptions on 2 ends of this spectrum, if you will, the tensions that exist. On the left side is this traditional utilitarian basic clinical science model. On the right is this more holistic education. And this is what the learners were telling us through their evaluations collectively over 5 or 8 years, is that if you look at the arrowheads in the center, the arrowhead size is different. So they see the importance and relevance of HSS and SVP, that's skewed to the right. But when it comes to their professional identity and how some of them view their traditional role, or the idea of content coverage or curricular time, or the fact-based learning, there is a preference for not diving into the complexity of medical education, but to look for the fact-based, look for the curricular time that is basic in clinical sciences, and to look at it like there's content coverage. I'm being a little pointed just to make the point. Clearly there's gray. But there is this tension that exists from the learner's perspective around HSS and SVP. Please, Luan, comment if there's anything to add there.
And as we're moving on in this, really, what I'd love for you all to do, if you are teaching HSS comment, just throw it in the chat box. How are you assessing these comments or these concepts? And what is your greatest challenge that you're facing? Because I think this is where our work right now is firmly embedded in this area of how do we assess this? How do we move this forward? And we think about this in 2 different ways. There's first of all, the programmatic evaluation, and this just demonstrates the Kirkpatrick model, but we're really trying to move this beyond the course evaluations and the surveys. satisfaction is hard in this. We know that this is sort of the broccoli of medical education right now. And students don't always, because they don't have the depth of understanding, they don't, sometimes they have more or less confidence than what they should have. And we know that's not very effective. Multiple choice exams and GQ comes into this as well. Multiple choice exams are really incredibly difficult. It is incredibly difficult to write good questions around this because the complexity of these topics is so rich, and it's where that discussion comes about. I think our real opportunity is how do we move this into the behavior sector, and how do we measure behavior? This is also a wicked problem, though, because medical students don't make independent decisions at the bedside. And how do we know when their decisions would have been different than their attending or residence decisions? And it is really impossible to tease that out. And of course, then if you're looking as they move into the residency program, how much of that is actually influenced by the environment in which they live and work. And there's an AMA ACGME study that was done that looked at schools that were involved in the AMA consortium. It's specifically those that were involved around health system science. And what they found is that there were a couple areas, if we looked at the milestones into the beginning of residency, that there were some areas that had marginal improvement compared to other schools, but most of them there was not a significant difference. And yet there are significant examples of how students have made tremendous changes within their schools. And how is that reflected as they move into residency, and what is that tension, and where does that lie? And then we really, thinking about how to move that into the results, and with the patient outcomes, the big data, how do we actually look at schools together, thinking about that? But I think really for many of us, we're really aiming, like, how do we move that into changing behaviors at the bedside, and then ultimately transforming that to improving our clinical outcomes for patients in the US. Jed, any other comments on that before?
Yeah, I'll just share an anecdote. So when you look at level 3 behavior, I mean, we're skewed to the left. I mean, we don't have a lot of things to the right, so we skew left. When you look at most clerkship directors would say, well, we're about assessing learners' skill in systems-based practice in the clerkships. It's most of our assessments, I'm assuming, have the 6 core competencies or whatever your EPOs are for your medical school, but systems-based practice is in there somewhere, presumably, for at least most. But when you look at, if you have a non-applicable or non-able to assess button, it's just been interesting to talk to some assessment leaders at schools, because the range that I have heard of that button being clicked is anywhere from 5 to 49% of the assessments, which is just, the display is amazing. This is all anecdotal, but it's the idea that when you're with a faculty member and you're on the pediatric service, which we know social determinants of health are everywhere. There's teaming going on. There's all these concepts and competencies that ideally the learner should and could be exposed to, but 2 out of 5 of the assessments are saying we can't assess it. There's so much to be unpacked with that, so much work to be exploring with that, and it's just one of the areas that we need to be focused on, I think.
And sort of as Jed was discussing that, we're really talking about our student assessment really drives our programmatic outcomes. But again, we are incredibly focused at looking at our students at the bottom of Miller's pyramid, and the knows how. But those assessments, in my mind, don't really get to the root of what students may or may not know. And it's like writing ethics questions for the USMLE. They're incredibly hard. We know all sorts of stuff happens in real life, but when you write it on a question, it becomes painfully obvious as to what the correct answer is. And so how do we actually begin to move this up? And how do we move it up in a way that is actually meaningful, that our learners find value in, and also recognizing the tensions of time and how much time it takes to grade some of these, and how do we, it's difficult to carve out time for everyone, and we probably actually don't have the mentoring ability to carve out individual quality improvement projects for everyone. And at least my approach and sort of initially designing a curriculum around this was focusing on what is the baseline content that every single medical student knows, and then recognizing that we have a cadre of students who are really passionate about it, who want to be embedded within quality improvement projects within their medical school experience. And we were able to carve out a distinction track that really helped us to pilot some of these assessments, to have a better idea about feasibility and scalability. And probably much to the chagrin of my distinction track leader, as things would work well in there, we would peel them off and try to actually incorporate them into the curriculum. I think the other challenge specifically around the workplace-based assessment is a lot of this is dependent upon the types of clinical encounters that the students experience. So how do you bring this in a meaningful way? How do you incorporate that? And how do you link that back so that the student really has the opportunity to demonstrate their knowledge when they do have this deep skill set? And that requires then that the faculty member know how to incorporate that into the workplace, and allows the student a space and an opportunity to share that knowledge, as opposed to just focusing on, presenting the patient in the very traditional model in which we have historically, and around which many of our clinical evaluations are built on. There have been changes relative to step 1 and step 2. Historically, the things that could be labeled health system science concepts embodied less than 7% of the content for USMLE step 1 and step 2. There have been proposals in really moving this through and integrating it more to a more substantial component, maybe driving up to 15 to 20% around these concepts. But again, probably not the best way to assess the students. I do think that this is potentially an important driver for increasing the students' emphasis on this area, because step is incredibly, particularly step 2, is incredibly important to students in terms of their performance. And that at least does help drive that along and have them focus on this as a topic of study, as opposed to traditional feelings of this is a soft skill. And I think most of us would recognize that we probably use these HSS principles much more in our everyday clinical practice than what we are using the Krebs cycle or some other basic skills that we have spent a tremendous amount of time on along our educational continuum.
This is our last slide. We wanted to present this it's in the assessment section, primarily because the other angle to take on it is physicians' perspectives and perceptions of their own skill. So this is a study, this comes from work, I'll cite Dr. Britta Thompson, Dr. Amy DeWaters, Dr. Aaron Miller at Penn State, who really drove the study. But this is a study of residents and faculty, several thousand from across 11 US academic health systems. And this on the y-axis is a top box score. So these were Likert scale questions, and 4 and 5, we clumped them together into top box scores. And then the x-axis are the different domains of health system science, at least 7 of the core areas. So the dark blue bars are the responsibility. This is the respondent saying, it is my responsibility to be practicing all these domain areas. And you can see the responsibility bars are upwards of, some of them are high 90s. So interprofessional collaboration, health system improvement, pop health does a little bit of a drop off, but by and large, those dark blue bars are pretty high. So there's a high responsibility perception. The ability is in this yellow bar. I'm sorry, the legend is off. That did not transfer well. So the yellow bars are their perceived ability in it. And you can see this gap that exists, which we're terming the responsibility-ability gap. I have high responsibility, but my ability to do these things, like social determinants of health, for example, it goes from 90 down to 35%. It's a big gap. And then the learning environment, which gets to Paul's comment a little bit in the text. The learning environment it needs to be conducive. It needs to provide the affordances for the practice, learning, and teaching of these different areas. They're not divorced. They're very similar. And the green bars are their perception of the learning environment. Does the learning environment allow us to practice, learn, and teach this? And there's also a gap there too. So we're just highlighting the fact that the responsibility or one's professional identity seems to be pretty darn high for HSS and systems-based practice, but their ability is low. And this is faculty and resident physicians, the same individuals who are working directly with our learners, your faculty on your clerkships, filling out that assessment of systems-based practice. So we have a complex challenge that's at play. There's a lot of good in this data, and it does unearth a lot of the complexities that do exist. So I think we'll close it down, right, Luan? I'm happy to take any questions. Please share any comments. And thank you for having us. And thank you, Luan. I love presenting with Luan. She's been a colleague for 10 years. It's a highlight to work with Luan.
I'm going to stop sharing for a moment just so we can see folks and I can see the chat box and if we have questions.
Please, Elise, go.
Sorry, and I had to come in late, so I apologize if you mentioned this at the front, but your last slide, I guess, would emphasize that as part of bringing in this health system science curriculum will require a significant amount of faculty development. And I'm wondering if maybe you could just comment a little bit on how you maybe how you've approached that. As a faculty member who feels unprepared to maybe teach this in a formal way. I feel like I can do it in the way that these things impact me on a daily basis, but in a more formal way, I feel very unprepared.
I can start, and then Jed certainly has tons of experience in this. And I think the question is really, how do you actually develop a faculty development program that meets everyone's needs, and recognizing that some people are going to have a significant amount of time for this and really want to be that champion. And so when we first started, actually before we even implemented any curricular pieces, we recognized that we did not have faculty who were ready and willing to step into leading this. Now, I would argue that many of them actually had some of the skills that they needed, but they were uncomfortable with it. And so we developed a year-long faculty development program that worked with them and really laid out all of these concepts in a deep way that actually incorporated doing a quality improvement project. We definitely had more of a bend in the beginning on the patient safety, the QI component of it, but it also could be an educational project too, an educational QI project. And so we, recognizing that as we started this, we needed these to be the leaders and champion for change within our curriculum. We actually collaborated with our College of Education to offer classes in instructional design. And it, not only did it include the content of health system science, but it incorporated how do you actually design curriculum around this. So there was a twofold project. What we found out the hard way is that is a whole lot to ask of busy faculty members, even though we were buying out time to help make that happen. Over the years, as that transition and we had some of the core build out, we transitioned to having interprofessional teams. So we actually sought out interprofessional teams within clinical learning environments. And we were really looking for modeling these behaviors at the bedside. And so we really did a dramatic shift. I think traditionally a lot of our HSS work is done by a few people within our clinical departments, and it's not incredibly apparent to the rest as to that's either their responsibility or how to make it happen. And I think you have to couple that with smaller manageable bites for people who don't have the time or the interest to dedicate a year. So how do you capture that in a couple of half-day workshops or at the departmental level so that you're able to ease it in and hopefully build interest and facilitate some of that knowledge? And Jed, I'll let you hand it over to you.
Yeah, I'll be brief. So the faculty development program, I think, is one piece. East Carolina, we had one at Penn State for 7 years. We have the National HSS Academy, and I do think it's one pie piece to this larger picture. I will say for clerkship directors who might be on the call, I think that there is inroads to be had where it's not professional development for the faculty writ large, everybody, because that's a big, complex challenge. I do think there's a number of things that we could do by building assessments centrally within clerkships by clerkship directors, assistant clerkship directors, education leadership at the medical school that delinks it a little bit from the faculty on the front lines, just to make sure that we're reaching those those competencies for our learners. And there's novel things that are out there for that, but it's in my head, it's a multi-pronged effort. That's what's needed. I see David's hand. I see Kathy there too.
I was interested in the example you showed us of Kaiser, of having the whole group work on a project. I've seen some healthcare management programs that worked real well, where they had the whole course, the whole cohort work on a project. And so I thought that was a really good idea that I hadn't thought of, as opposed to individual projects, which take a whole lot more time per student. But I was wondering, do you ever see it getting incorporated into scholarly projects?
Yeah, I'll take first stab, Luan. I think, to be honest, I don't think it's an anomaly. From my perspective, I haven't seen data on this. I think many medical schools in that QI, patient safety, health system improvement, team-based project lens, I've heard of many medical schools that do that. The challenge is the degree to which that project gets implemented. But there's a lot of learning competencies, even in the progenitor early steps of identifying a problem, going to Gemba and identifying what it is, designing, like they are early milestones that can then transition in the residency. So I think we can do a lot better, David, in that zone. But Luan, please extend that.
I would say the other thing is this is an opportunity for institutions to elevate that. So we put more for the people, for our Teachers of Quality Academy and for our students who are in the distinction track, as well as others, because once it started, people were interested in joining on. We actually, so we added a HSS symposium in which would allow students to participate. And we did a lot of training, particularly with our faculty mentors, but also with our students around Squire guidelines and how to actually what was the difference between research versus QI work, and how did we actually turn this? And we also do follow-up meetings with faculty in order to help them and offer them consultations and how to transition that to a scholarly project.
So I just want to comment on the link I just put in. Dr. Xana Chang, Edgar Perlisi at UCSF and team. That's remarkable work going on. It's one of the best I've ever seen in the literature, and it's pre-clerkship. And there's many examples, but I just want to highlight they're doing really great work. Kathy.
Hi there, Kathy Whitcap from Uniform Services University. Thanks, both Jed and Luan. Great to see you both and hear this talk. My question is around assessment. We're really, struggling most with that. We've been trying to implement, and I would say the clerkship year is where it's kind of our last phase of implementation of trying to, and the assessment piece is really a challenge. And we are also in our self-study for our LCME visit in 2024. And so there's a huge focus right now on assessment of all the, these beautiful HSS learning objectives that we've added to our curriculum. And now we're trying to figure out, oh no, are we assessing these properly and how well? And so we're actually, so my question, I don't have a solution. I just appreciate all these little bits and things that we'll try out in our curriculum as well. But the NBME exam, we did it our first year as kind of a pilot baseline to see where we are, and we're thinking about bringing it back on now, especially as we're struggling with figuring out how to do these assessments. So, and doing it as a real low stakes post clerkship exam for our students, just kind of pass fail for them, but for us to kind of get a sense of our curriculum, maybe some sort of assessment, almost an evaluation of our curriculum more than an assessment of the students per se. But I'm curious, how are you all using, you all in your facility, your institutions where I know you're, probably way ahead of a lot of folks. How are you using these tests, or how are you seeing them being used well, or, in a productive way? I'm already, with our clerkships, it already bothers me that we do so much assessment with the, subject exams rather than clinical assessments. So I worry that, everything's going to be multiple choice. So just curious your thoughts on that. Thanks.
So I'll give the caveat of I was involved with the development of the MBME exam, and I used it only for programmatic assessment. We administered it at the beginning of medical school, and then we administered at the end because we had an integrated curriculum. So it was, while each individual assessment was graded or assessed in some way, that we were really looking at the change. And what we found is over time, people had an increase in skills coming into medical school, and we could show a gap of increased performance as they graduated. But we did not use it for individual student assessment because it is so interspersed with so many other topics. So we used more of those individual exercise and assignment as markers for their assessments. With our students who are actually in this distinction track component, we use more of a portfolio approach though.
At least we have time for one more.
Thank you.
Jennifer?
I think Gary's the boss, but
Okay.
sure, I'll say yes.
Okay, thank you.
Yes.
Appreciate it. Thank you for a great talk. And Jennifer Schwartz from Indiana University School of Medicine. And it's so nice to see that everyone's grappling with the same items. Couple of questions. Number one, listening to the discussion and the individual ways folks are considering developing internal assessment pieces. It would be glorious if there was a repository in which we could better exchange ideas and share. It always feels like we're all trying to invent the wheel, so to speak, and customize it for our center or, but there may be opportunities to cross-pollinate. The second is, and I'm probably sounding like a broken record to the NBME because I always go up and I say, you permit us to customize exams. What would be great is if we could customize, utilize your HSS exam and really just pull the questions that apply to the content that applies to our curriculum. I don't know, you guys are far more involved than I am at that level, but just wondering if others have approached the NBME in that regard, just utilizing it within, again, for mainly a programmatic assessment, but there's just so much content that we don't cover to the degree that those questions necessitate. So just some comments. Any comments?
I think there have been lots of historical discussions around how to best use that. And was it modular exams, at least of the modulars? I think this work is really early and there's probably needs to be tremendous more work on on building a larger scale in order to probably do that really well. And some of this is, I certainly don't want to speak for them, but I do know in the terms of the challenges of writing the questions, but I think there's probably better opportunities for us, especially as we move forward. And how do we move that assessment, whether it's at a national level or individual, to be directly related to patient care as opposed to the multiple choice questions, which probably don't assess what we need.
My closing thought, Jennifer, on the curricular repository, I've been in conversations for a decade on that, and Luan and I are laughing because I initially wanted it really, really badly. I have learned, though, it's really complex too, based upon local expertise, how you transfer PowerPoint slides or methods into another institution based upon that content expertise or the goals that might be a little bit different. So it's a yes and there's a lot of caveats to that based upon the local contextual factors that I think is a reason why it hasn't been built. But I don't know why it hasn't been built.
We've been asking the question for a long time.
I just think it's hard to build. Sorry, Gary.
And there still is an opportunity to put things in MAEd portal, sort of to be able to drive this from us using a shared vision without, there's an existing structure that we can use.
Absolutely.
Thank you both.
Well, thank everybody for coming today and participating in this, and especially thank you to Jed and Luan for the presentation. With that being said, we're a little bit over, and so we'll close this out, and the recording will be posted on the website hopefully this weekend.
Thank you, everybody.
Thanks.